Next, Roberto Spiegelmann is going to actually now talk about this amazing product, the Automated Brain Metastases Planning System.
Thank you. Good evening. I try to be brief because I have a dinner invitation. As you well know, and has been mentioned, surgery, radiosurgery, and whole brain radiotherapy have been used for the last 25 years, in alone or in combination. There are several advantages of surgery that still keep us doing that. We can get an immediate relief of site-related deficit. We have a fast resolution of involved edema. It's technically straightforward because there is a clear delineation of a metastasis from the brain tissue. They are usually very accessible because they are mostly in the cortical, subcortical surfaces. And the stereotaxis or lately neuronavigation minimize access trauma, at least for the surgeon. Still, more than 50% of patients with brain metastases are not good candidates for surgery, and that is because either tumor inaccessibility, multiplicity, or extensive systemic disease in the patient. And there are drawbacks, important drawbacks to surgery. One of them is the possibility of infection, bleeding, and very importantly, seeding, something that we almost exclusively see with surgery. This is the case of a patient with a melanoma. 1 month after surgery, 3 months after surgery, extensive meningeal spread, and this patient is gone. Radiosurgery has been in use for more than 25 years now, and this is the first publication by Dr. Volker Sturm from Köln in 1987, which was a proof of concept that you can do radiosurgery to metastases. And in my particular case, my proof of concept was this patient in 1993. This patient had metastasis of renal cells carcinoma in the cellar area, and he had gone through twice transphenodal surgery, whole brain radiotherapy, and he was deteriorating rapidly. And we gave radiosurgery to this patient. On the right, you see the scan 3 months after surgery, and I was sold out that radiosurgery was the way to go. Still, there is a problem that has been mentioned not enough, not here today and not in the literature, which is the troublesome definition of tumor control that we encounter with radiosurgery. Oftentimes, we have a problem of judging in a given patient, as this one here, if we have a recurrence of tumor or radiation injury. And usually the tools that we have at hand are not good enough to make a good decision. This has been used in the last few years, the so-called T1, T2 mismatched. I have been using that, and this is based upon the fact that here you have a tumor that was treated by radiosurgery. You can see the T2 images showing a mass, and the T1 post-contrast images showing more or less the same mass. And a few months after radiosurgery, we have this contrast-enhancing lesion. Is this tumor recurrence or this is radiation injury? And the decision is very important to the destiny of this patient. And we believe that this was radiation injury because in the T2 you don't have a mass. And so if you don't have a mass, this probably is not tumor recurrence. It works, but it not works all the time. If you have a severe radiation necrosis, the necrotic mass will show up in the T2 images. And this is a work that has been done in my institution by another investigator, the delay contrast extravasation MRI, and it's working very well. It's based upon a very simple hypothesis. You do 2 series of MRI, one the normal MRI, and one MRI done 70 minutes after the first one. You fuse the images and you subtract the images, and then you see, and you color code what you see. The red is areas that remain with contrast enhancement 70 minutes after the first injection, and the blue areas are areas that have no contrast remaining 70 minutes thereafter. And what this investigator found was that the areas with delayed contrast enhancement represent radiation injury, and the reason is that the vessels in that areas are leaky because they are damaged. And the areas where you have active tumor have normal vessels, and that clear the area very rapidly, and this represent active tumor, the blue areas. We have done an extensive investigation of this hypothesis with surgery and histology of these patients, and in already close to 100 patients with histology, this works. And the good thing about this method is that it's very high definition MRI, because it's the basic MRI that you are doing for diagnostics. Is the same MRI that you are doing for trying to differentiate radiation injury from recurrent tumor. Now, whole brain radiation therapy has been mentioned a lot in this evening. It's the classic approach in later years, mostly for patients with multiple phasing. But the problem with whole brain radiation is not only the delayed effects, but the acute effects, the hair loss that tells everybody that this patient has cancer, the acute mental effects that are underrated, fatigue and somnolence, and the fact that whole brain radiation therapy is almost non-functioning for frequent tumors in the brain like melanoma and renal cell carcinoma. Well, whole brain radiation therapy is not curative because the doses that we can administer to the whole brain are not curative doses, and this has been extensively examined. And the fact that leukoencephalopathy develops after whole brain radiation therapy is well known, and you can discuss what is the incidence, but there are many papers coming in the last few years proving that this is something that occurs very frequently if the patient lives long enough. Well, hippocampal sparing, it won't work for this patient that had both hippocampi involved in the disease. So probably it's worth trying, but it won't help in every patient. So whole brain radiation therapy is not curative. It results in cognitive deterioration in the long term. On the other hand, it has been purported that you can get less incidence of new brain disease in the short term, and also that new disease may generate cognitive deterioration. But we cannot forget that whole brain radiation therapy is only effective for tumors that are there when you are giving this treatment. What about the combinations of these therapies? What about radiosurgery and whole brain radiation? Well, it has been proven that radiosurgery, as added to whole brain radiotherapy, increases the local control. And this paper, which has been mentioned in this evening, is a very important paper that brought back the need or the good issues about whole brain radiation. It proved that relapse after radiosurgery alone is much more important locally and distally than in patients with combinations of radiosurgery and whole brain radiation. But there were, as it happens, methodological problems in this paper. One was the selection of dose, and the other was the definition of recurrence. The patients that received whole brain radiation therapy as an addition to radiosurgery receive a 30% inferior radiation dose in radiosurgery. That means that some patients with tumors that were larger than 2 centimeters received less than 13 gray for a metastasis. And as has been mentioned in this evening, this is almost for sure resulting in recurrence of tumor. And troublesome definitions as for tumor control or tumor recurrence, because the appearance of a lesion several months after radiosurgery not necessarily represent recurrence of tumor, even if this area has an heterogeneous enhancement, because many of the tumors we treat have an heterogeneous enhancement to begin with. And the important fact that was mentioned in this paper anyway was that N-Smith, the combination of whole brain radiation and radiosurgery or radiosurgery alone had no difference in survival. The median survival time was more or less the same for patients receiving radiosurgery alone or a combination of treatments. So the take-home message in any case for this important paper was that you can do radiosurgery alone, and if you follow the patient well enough, and this is usually the case for patients receiving radiosurgery, salvage radiosurgery could result in the same prolonged survival and good local control. Well, actually, we know that there are many drawbacks to whole brain radiation therapy. And the main reason really that we are still doing it is that doing radiosurgery for multiple brain metastases is lengthy, is cumbersome, is very costly also for the health providers. This paper by Yamamoto, those of you that, Yamamoto is a neurosurgeon that uses a gamma knife. And this guy has been doing radiosurgery with a gamma knife for more than 20 or 30 metastases for many years. And probably he's a little bit of an extreme, but he has proven the case that you can do it. But just imagine doing radiosurgery for a patient with 30 metastases with a gamma knife. I mean, you need several days. But this guy has been able to do it and has been able to get other people in Japan to do exactly the same in order to publish this paper that the take-home message is that the survival of patients with more than 5 metastases, 5 to 10 metastases, is comparable to the survival of patients with only 2, 3, up to 5 metastases if you only use radiosurgery. So it's a proof of concept. And there are other papers that prove that you can get very long survivals and good control using only radiosurgery. So if you follow the patient closely and you increase your diagnostic power with good imaging, salvage radiosurgery for new metastases, you can get very good results and you can bypass whole brain radiation therapy. But the need was to get a better tool for doing multiple brain metastases radiosurgery. And this is this module that we have been working with in one of the hospitals I work in Israel in the last few weeks. And this is the multiple met treatment module by BrainLab, which has been developed really so that everybody can use it. Very, very simple. Even sometimes it's too simple because it's completely automated. This is a movie, and try to be brief, but some of the things you are familiar with if you have been using BrainLab equipment. Fusion is a cinch. It takes place in something like 2 seconds. The tools in order to see if the fusion is accurate are more or less the same that you may be used to. I don't think that I can interact with that, but I don't see a ruler here. The most important development is the new smart brush. This is something very nice. You have to recognize the tumor, you have to give a name to the tumor, and you have to identify it as a tumor in order for the software to attack it. Now, outlining the tumor is very easy because you do it in the axial image, and once you've done it, you click and the image centers in that tumor. So you define it in the coronal, the sagittal, and you're done. The full tumor is defined. You can go through other tumors. The process of identifying and outlining the different tumors is a matter of 2-3 minutes, even if you have a good number of metastases, given that you can use these very nice tools. And you can still interact with the smart brush because you have a conventional brush that you can use also if you are in the need to fine-tune your results. I'm going to go over this if I can. Yeah. And now, once you have outlined the tumors, you go to the treatment planning. You have to identify the position of the patient onto the couch. And once you've done this, you click OK, and the software is calculating the radiation. You have to define a certain algorithm, which in this case is that we select the 20 gray dose as the basis for treating these tumors. The tumors are outlined, they are color-coded. You click in one, you have the opportunity to change the dose if you think that the 20 is not good enough, as we are doing here. Here is a tumor in the brainstem, so we are going to reduce the dose to 1800. We are going to do more or less the same for this tumor that is close by and it's relatively big. And once we have selected the dose for all the tumors, you click done. I hope it will happen soon, and the software is calculating. And you have the outlines. We don't want to see the brain itself. And here we have each tumor. You can click on it, very rapidly scroll on the axial, coronal, and sagittal images to see if you are happy with the coverage and with the lower ISO those lines. And basically, you are done. The one other thing that you would like to see is how actually the treatment will be executed with the high-definition mini-multi-leaf collimator. And this is what we are seeing here. This is a mock-up of the skull, and the gantry is rotating, and you can see how the mini-multi-leaf collimator adapts to each and every one of the metastases. Not all the metastases are treated in one pass. The machine sometimes goes back and forth, and in the going back treats metastases that had not been addressed in the first pass, and the collimator rotation can be changed to take advantage of this rotation to get a better coverage, better confirmation of the treatment. Now, for 8 metastases, the treatment planning time was around 20 minutes. The treatment time was 20 minutes, and this is the most important thing. It was like treating one single metastasis. And the total beam on time was 6 minutes. We treated so far 5 patients, and this is very fresh. We started something like 6 to 8 weeks ago. We have had no acute toxicity, and we have only 1 patient with a partial result. I mean, this is 1 month after treatment. The before is on the left, the after is on the right. And it's funny that you need that I mean, we have done, our physicists, Daphna Levine and Efrat Shekel, have done extensive QAing before each and every patient, but somehow you need this confirmation of seeing that you're having an effect in order to be ready to believe that this is really happening. Of course, you can do the same with Rapid Arc. We have been doing that with Rapid Arc before this module, but what we have seen is that first, it's much more time-consuming in the planning stage, not in the execution stage, of course, and that the lower isodose lines were less tight with Rapid Arc, although the conformality, we could achieve good conformality also with Rapid Arc for the tumors themselves, and this is just an example of it. And you won't be able to see the difference here, but this is only one of those patients. Maybe now you can see that the interrupted lines are the Rapid Arc that have the same or even better conformality, but in the lower isodose areas, the Rapid Arc wasn't as good. And I promise to be brief. So the logistical and the technical barriers for doing radiosurgery for multiple brain metastases are done. The rationale is very strong. It's extremely cost efficient, and it appears to be very effective, and it's not a surprise. The issue is if this is requiem for whole brain radiotherapy or not. I believe it is. I'm convinced that once we have this tool, there are not many reasons to continue with the whole brain radiotherapy. This is a Mac. I cannot use a Mac. Okay. Anyway, we are finished. Thank you.